Good morning, everyone. Thank you, Dr. Vishal, for setting the context of this. I think it is a very useful paradigm. Externals से हम सिर्फ एग्जाम में मिलते हैं, उससे पहले एक्सटर्नल ऑर्गेनाइजेशन को प्रेजेंट करना by itself is a big confidence booster. So without much ado, let us start. Welcome, Dr. Pankaj Verma, Head of the Departments of the Young and BMMC. Sir, can we begin if we have your permission?
Yeah, good morning, Dr. Paramjit. Good morning to all the seniors. It is really heartening to see Dr. Neena Bora, Dr. Ashwini Kumar sir. They are the first one to join. Today, the case will be presented by Dr. Niharika. Cases regarding PMDD, which is having, it started with the luteal phase dysphoric disorder, then severe PMS. In DSM-4, it was labeled as PMDD, and now DSM-5 is treating it under depression. So these are quite interesting, especially when we are talking in terms of Delhi people, because in a recent meta-analysis, they found that up to 64% of the females, they might have PMDD, which is a very significantly high number, whereas worldwide it is recognized at 1 to 8% only. But the recent this meta-analysis quotes when they were comparing throughout these states that Delhi has the highest number, around 64%. Either we are missing it or we are under-diagnosing it. Let's see. This case might give you some insight. I welcome Dr. Manoj Kumar, who will be the case consultant, and I invite Dr. Niharika to start. Okay. So, Dr. Niharika, we can start. Okay. In between, what we'll do is after the negative history, we'll have a break. We'll take a question answer session. Then after personal history. Then after MSc, and later on we'll decide as and when, if there are more questions, we'll do that. Okay.
1 second. Before you go ahead, Dr. Manoj, welcome to DPS Case Conference. Can you hear me? Dr. Manoj? Hello.
Good morning, sir.
Yes, I am able to hear you, Dr. Vishal. Please continue with this session.
Okay. Yeah. Okay. Any opening comments you want to make, sir, before we start?
No, actually, this is actually a case which may not be a typical case of PMDD. We brought this particular case because this is the kind of an atypicality that we have seen in this particular case, and it is not just PMDD which will. This is something which is going to give a lot of insight to the researcher as well as to the people, those who are managing the cases of psychotic disorders.
Okay, thank you so much.
Thank you,
Dr. Manoj, for your opening comments. Dr. Niharika, please, can you start your screen share? And I will request everyone else to please mute their mics. Thank you.
Yes, sir. Good morning, everyone.
Yeah, you continue, Dr. Niharika.
Good morning, everyone. It's an honor to present the case in DPS Case Con. Thank you for the opportunity, sir. I'm presenting the case in which treating consultant is Dr. Manoj Kumar, treating senior resident is Dr. Arundhati, and presenter being myself. Here is the case. Mrs. V, 36-year-old female, educated up to 10th standard, married for 19 years with 3 children, currently unemployed for past 6 months, belonging to a Hindu nuclear family of upper-lower socioeconomic status, resident of Ghaziabad, urban UP. Informant being patient herself, Mr. D, husband, 46-year-old male, studied till 12th class, currently working in a private company and living with the patient and old medical records. Informants are reliable and information provided is adequate. Presented with chief complaints of महीने के कुछ दिन पहले नींद में परेशानी होना, महीने के दौरान मन सही नहीं रहता, महीने के कुछ दिन पहले और दौरान ज्यादा टेंशन हो जाती है, महीने के समय कुछ करने का मन नहीं करता है. Duration of illness is from past 11 years, and it is of abrupt onset and episodic course, with precipitating factor being onset of each menstrual cycle, predisposing factor being family history suggestive of similar psychiatric illness in mother, and poor compliance to medication with nil perpetuating factors. History of illness. Patient B, 36-year-old female who had achieved menarche at the age of 15 years with regular menstrual cycles of 28 to 30 days, with 2 to 3 day cycle of regular flow and soaking 2 pads per day for many years, was apparently well, maintaining until the age of 20 years when she and her family members started noticing that patient was having sleep disturbance 3 to 4 days prior to the onset of her menstrual cycle. Usually, the patient used to have regular sleep for 6 to 7 hours, as she would go to bed at 11 p.m. and wake up at 6 a.m. without any difficulty during the night time, and would feel refreshed and energetic in the morning. But during the menstrual phase, patient would go to bed at her usual time and kept lying on the bed and would fall asleep after 2 to 3 hours with difficulty in initiation of sleep. Anxious palpitations during the night time. She would wake up at her usual time and felt tired and fatigued the next day in the morning. Even if she tried taking a nap in the afternoon, she could not get one. Earlier during her menses, patient did not experience any fluctuation of mood. She would be performing all the household chores well and used to engage by herself in any ongoing family conversation. Her appetite, bowel, bladder, sexual functions were adequate in between the cycles, and according to the patient and family members, since last 11 years, during her menstrual cycle, patient would be seen to be irritable on trivial issues that she used to handle calmly. Patient could not provide any apparent reason for her behavior and would get into frequent verbal altercation with her husband, children, and other family members. She would later express distress that she is not able to control her anger. Earlier to the onset of her symptoms, during and prior to menstrual cycle, patient used to perform all the household chores and was pursuing her job regularly. But now, during the cycle, patient performs the household chores and even small tasks seems challenging to her. But she would be able to do some work with the help of her husband. Patient would remain to herself for most of the time of the day and did not have any conversation between the family members as she used to do prior to the menstrual phase. Although patient would interact when approached by family members and even would sit along with them for some time. She expresses to her family members that she feels sad most of the time during the day and doesn't feel like doing any work and worry regarding the same. During this phase of 8 to 9 days, which includes 3 to 4 days prior to the onset of menses, 2 days of menstrual cycle, and 2 to 3 days post her menses, patient also stops going to work. She feels tired and she feels that she'll not be able to perform work well and takes leave from work and remain distressed regarding the same. Along with that, during the initiation of menstrual cycle, patient would be seen worrying excessively regarding her children and her husband and remain apprehensive whenever her children went out of home to play with others. That what if someone hits them accidentally or they might not get into fight with other children. She would have palpitations and excessive sweating, which would last until the children and husband came.
I will request everybody to please keep their mic on mute.
Owing to this, would many a times try to stop them from going out, but allowed them after repeated demand from her children. Similarly, whenever her husband went out to work late during the night shift or returned late from work due to some reason, patient would remain tense regarding him and also became suspicious that he must have gone to some other woman and might be having illicit affair. So she would call him 2 to 3 times and remain anxious till he picks up the call. And after having conversation, she would calm down a little and wait for him to return back home. Patient gets short when other family members explains her. However, the patient never followed her husband or checked his phone or stopped him from going to work because of that. On being asked, patient tells that she is fearful and worried about him leaving her because of the illness and feels insecure. These things would resolve spontaneously in 2 to 3 days when her menstrual cycle gets over. Prior to the cycle, patient would have 3 meals of 2 to 3 rotis each meal with some in between snacks. During the menses, she would not feel hungry much to have proper meals and eats lesser than her usual. During these cycles, there were no complaints of specific food cravings, breast tenderness or swelling, and no signs and symptoms of bloating or weight gain. Once her menstruation stops, patient would become asymptomatic in 2 to 3 days time period and would remain fine as her prior self for next 18 to 20 days, and she'll not be having any symptoms during this period. And during the intermenstrual phase, patient usually perform all the household chores by herself with no difficulty in pursuing her job, and would go to job regularly by herself and takes care of her children and get them ready for school. Along with that, her relations with husband were also good, and she would not worry regarding her children and husband. Patient would also remain socially active and interact well with others without any difficulty. Whenever patient was taking medications, she would remain asymptomatic and was maintaining well on medications. And as she improves, she stops taking medication in between and again have symptoms during the next menstrual cycle. Negative history. No history of persistent pervasive low mood, loss of interest in earlier pleasurable activities, no history of worthlessness, hopelessness, helplessness, or pessimistic view of future, no history of difficulty in attention and concentration, forgetfulness, no history of any acts, thoughts of self-harm, no history of generalized anxiety during day and night, or any specific phobia, no history of elevated mood, increased energy, tall claims, no history of hearing of voices unheard by others, no history of any thoughts spoken aloud being inserted or being withdrawn, no history of repeated intrusive thoughts, acts, images, impulses which patient would find irrational, no history of any maintenance of abnormal posture for prolonged duration. There is no history of nightmares, night terrors, no history of any snoring, waking up in the night due to shortness of breath, no history of any contraceptive drug usage or any hormonal therapy taken by the patient, no history of any dysmenorrhea, oligomenorrhea, and menorrhagia, no history of passage of clot or any intermenstrual or postcoital bleeding, no history of abdominal bloating, abdominal pain, joint or muscle pain, no history of fever, any other neurological deficit.
Okay.
In treatment,
Can we
Just
hold on,
a wait.
Dr.
Just
Niharika?
wait.
yes, sir, yes, sir.
Okay. Yeah.
Sachin, go on.
If any clarification you would like to ask, Dr. Niharika and Dr. Manoj can help her.
Any
Anyone?
questions or clarifications at this stage, please? Dr. Niharika, I have a small question.
Yes, sir.
This suspiciousness was only limited to this period around the menstruation and not anyway in the intermenstrual period.
Yes, sir. She feels more insecure during the menstrual cycle phase.
Only.
Yes,
Yes.
sir. According to patient, yes.
Yes,
Sir.
yes, this is all right. Thank you, thank you.
Any other query?
I would like to add a little bit to her presentation. Am I audible, everybody?
Yeah,
Yes, sir,
Dr.
you are
Manoj, go
audible.
ahead, please.
Yes, sir.
Actually, the way that she has presented the case, like presenting complaint of mahine ke kuch din mein aisa ho jana, but actually it was never been like this. The patient has taken the treatment from the various psychiatrists before coming to Vibhas, and actually everywhere she will go and tell that the husband will take her कि मेरे पर शक करती है, मुझे चेक करती रहती है कि किसी से रिलेशनशिप तो नहीं है. So these are the complaints that the patient was, the husband was taking her to the psychiatrist and making the complaint, and the patient was diagnosed on the lines of schizophrenia, and she was treated on the lines of schizophrenia. But what used to happen is she used to stop taking the medication, and again, because it was a phenomenon which was occurring during the cycles, so again she used to become suspicious, so she would be put on medication. So by the time then she came to us, then we realized that there is something is very atypical about this presentation. How it is possible that the patient remains symptomatic for a few days and then remaining asymptomatic in between. So then we thought of the possibility that it might be related to her menstrual cycle. And then we explored it in a very detail and then realized that these phenomena are happening only during her premenstrual period.
Premenstrual period.
So it appears as from our presentation that it is that classically, the patient will never be knowing that it is related to her premenstrual symptoms. And moreover, she is coming from a background of not very educated woman. So she may not be able to recognize this. Only the thing is she will complain, मेरे husband का किसी से relationship है. Husband will also complain कि why she is suspicious for few days. So by the time actually she was clearly a case of schizophrenia from outside, but when we evaluated it, we find it a completely a different presentation. So that's what actually I wanted to add into her. And there was a genetic loading also. There was a reason for the people to be making a diagnosis because there is a genetic loading of schizophrenia in her case. So they thought in that line also.
Thank you, Manoj sir, for the clarification. That indeed makes the case much more interesting.
Okay.
Pankaj sir?
Okay. Okay.
Yeah. Any more queries? Okay, fine. Dr. Niharika, you can continue, please.
Yes.
Sir, I had one query.
Acha, okay.
Regarding the suspiciousness, it was not clear whether it was how much was the conviction and were others also, what did others have a belief about the same? Like if we're going on the lines of schizophrenia, as sir mentioned, maybe could be, maybe Dr. Niharika can clarify if how much was the suspiciousness, like what was the level? Was it on a delusion level or was it just idea level?
Yes, yes. I'll be coming to that in the MSc part. And
Okay. You don't want to add anything else right now? Okay, how serious this? Okay, fine.
Sir, yes, sir. I'll explain it in MSc part. Then, if is there any doubt, then I'll explain it.
It so
Okay.
seems, sir, that at this time at least the conviction was challengeable when someone would tell her she would rather be willing to accede to the understanding. It so seems from the history as she has presented.
Mhm.
But let us go ahead and see, sir.
Sure, sure.
Dr. Niharika.
Good
Yes.
morning. Good morning. Can I speak? I'm Dr. Brijesh.
Yeah, sure, sir.
I'm Brijesh Saran from Santosh Medical College. I'm an associate professor there. So I have a question to Dr. Manoj is there that what is the status of her delusion of infidelity is there currently at the presentation at IVAS OPD?
Sir, actually, when the patient came to us, actually, she came with the same kind of complaint that she is suspicious and she is, suspecting her husband character, and she has stopped taking the medication. So by the time actually when she came over here, when we realized that the patient is not that suspicious, only the thing is she started, saying, "मुझे पता नहीं क्या हो जाता है, that I feel, that my husband is not going to love me anymore. He will go to some other woman." But it happens sometimes, but most of the times, otherwise, actually, she is doing everything. So by the time actually when we cross-sectional examine on that day, when I saw her first time, I really find it very atypical that how it is possible that she will become suspicious for some days and then not the other part of the other weeks of the days, other weeks of the month. So then there is a reason for re-challenging the diagnosis, and there is a re-evaluate it from scratch, and then we dig out the possibility of this PMDD symptoms in her, and along with that one, the psychotic symptoms are happening only during these phases, which was later on confirmed by the patient as well as by the husband.
Brijesh sir, I think we can wait for the MSCs to be presented on the time of admission, but I think the clarification by Dr. Manoj suffices. Brijesh sir?
Yes. Yeah. Thank you, sir. Thank you. It's a really atypical case presentation.
Let us go ahead, Dr. Niharika. Let's please keep the time also in the mind. Dr.
Yes.
Niharika.
Yes, sir. In treatment history, patient has started taking medication in 2011 from a private practitioner, and she was started on tablet amisulpride 100 mg and tablet olanzapine 10 mg, on which, according to the patient and the records, response was good and there was no side effect. In between, patient was taking medication irregularly by herself from the pharmacy. Patient presented to IBHAS in 2022, and patient was started on tablet risperidone 2 mg and tablet escitalopram 10 mg, on which patient has shown good response with no side effects. In past history, there is no history of any other chronic medical illness and no history of any other surgical intervention. In family history, patient is first-born child of the family, and family history. In family history, there is history suggestive of psychotic illness in brother. Further details could not be clarified, and family history suggestive of similar psychiatric illness in mother. There is no history of diabetes mellitus, hypertension, thyroid disease, asthma, tuberculosis in the family. Patient is currently living in 5-membered Hindu nuclear family and currently resides in a rented Pakka house with a joint kitchen and separate bathroom with 2 rooms. Belonging to upper lower socioeconomic status according to modified Kuppuswamy scale. Patient's husband, 46-year-old male, 12th pass, working in a private company, is the primary bread earner, and patient herself is the primary caregiver for her family and the children. Attitude of family toward patient is supportive, and attitude of family towards the illness. Initially, they did not understand the nature of the illness, but after proper psychoeducation, now have adequate understanding of the illness. Interpersonal relations are cordial and no history of any substance use in the family. In personal history, birth and developmental history, patient born via full-term normal vaginal delivery at hospital with no prenatal, natal and postnatal complication, cried immediately after birth, and immunization status is not known. No history of any drug intake by mother, radiation exposure during first trimester, patient achieved normal developmental milestones at the age comparable to other siblings. Educational history, patient she started going to school at 5 years of age, and she was average in studies, used to have good relations with peers, and studied 10th standard. Occupational history, patient was working regularly in Hero Motors as laborer from past 15 years and currently not working from past 6 months because of ill health. Menstrual history, age of menarche, 15 years of age, patient is having regular menstrual cycles of 28 to 30 days and has menstrual bleed for 2 days, which is normal in flow and amount, and soaking 2 pads per day. No history of any abdominal pain, lower abdominal pain, dysmenorrhea, and no history of any intermenstrual or postcoital bleeding. In marital and sexual history, duration of marriage is 19 years. Patient has 3 children and all were wanted child and born via full-term normal vaginal delivery. Patient is not on any oral contraceptives. Religious history, patient is religious, positive attitude towards customs. She used to keep fast and visit temple occasionally. In forensic history, no ongoing police or court case on patient or close family members. Pre-morbid personality. In social relations, patient had cordial relations with family members and neighbors and used to interact well with them. In intellectual activities, patient used to spend her leisure time watching TV or talking to her family members and used to go out and buy groceries for the home. Predominant mood, patient would usually remain calm and relaxed in day-to-day routine. Whenever faced with stressful situations, she would handle them well. Character, extrovert, she would take responsibilities and takes her own decisions by self or with the help of her husband whenever needed. She would not rigidly stick to the rules and often flexible in her day-to-day activities. In interpersonal relations, patient always had a good relation with her family members and in-laws. Patient did not have much difficulty in adapting to her new environment and after coming to her in-laws. Attitude, patient was religious and used to occasionally keep fast and visit temples occasionally. In habits, no history of any substance abuse. Pre-morbid personality is well adjusted.
Dr. Niharika. Wait.
Yes, sir.
Any clarifications at this stage? Pankaj sir, can we go ahead?
Yeah, I just
Yeah,
want to know one thing. Dr. Niharika,
Yes, sir.
the case came to you last year, no?
Yes, sir.
And still we were not able to get a history about the brother and the mother.
So they are not having any documents. They said कि ऐसा ही problem को भी था, but brother का sir brother का नहीं available हो पाया sir.
Okay. Okay. Any other query?
Dr. Niharika, can you go back to the treatment history of this patient?
Yes, sir.
Actually, as we can able to see from 2011, she was on treatment, and most of the time she was being diagnosed on the lines of delusion disorder and schizophrenia. And she was continuously on these medication, amisulpride and olanzapine. And in between, whether she has changed, the husband has changed the psychiatrist also. And because the used complaint used to be कि शक करती है, and she's suspicious, she's abusive, she is creating a difficulty at home. So the husband used to has no other option but to take her to a psychiatrist. So somebody was asking about the level of the conviction, because the behavior was so problematic that the husband has felt the need to consult a psychiatrist. So, had it been a minor, suspiciousness which could have been tolerated by the husband, he would not have taken her to any mental health professional, because the problematic behavior was so much that husband felt the need to take her to the treatment for the treatment. But because the patient used to become non-compliant, she used to stop taking medication, and then he has to change, because the patient husband used to feel "Okay, now doctor sir will will be scolding her, why you stop the taking the medication." So he used to change one or the other other mental health professional. So by the time she, came to us in 2022, she had already visited 4 or 5 psychiatrists, and used to have a very poor compliance to the medication. But actually, whether the medication used to show us the improvement, or the patient's menstrual cycle used to stop, and then she used to have, improvement in her symptomatology, that is very difficult to discern. But there is definitely some benefit was seen with the use of these medication in the patient.
Sir,
It may be
Dr. Manoj,
because her irritability, maybe it's a
Mhm.
little bit of sedation used to be there. So the husband was also feeling the need to continue the medication, but because patient was not willing to take this medication, there was a problem.
Manoj sir, I agree with you because the symptoms are very transient here and only perimenstrual. The response is very difficult to gauge here.
Yeah.
Only efficacy of the medication could be prophylactic. That if the medication was on in the next menstrual cycle, she did not have such symptoms. Otherwise, the acute effect is very difficult to discern here.
Because everybody will say that medication will take its own time to show response.
Sir.
So, 10-15 days, it is very difficult to say whether the medication is showing effect or not. So
Yes, sir.
probably the effect of those medication are coming in the next cycle. And as the patient used to have, less of symptomatology, so they were continuing with the treatment. But it is the
Yes.
patient who was not willing to take the medication, and that is why they have to change multiple mental health professionals.
Yes, sir. If
Okay.
can you move ahead, Pankaj sir?
Just one point I would like to make here. Dr. Manoj has said a wonderful thing, that the attendant was afraid taking back patient to the same consultant. At times, we are so passionate about the recovery that we try to emphasize that do not leave the treatment. And at times patient gets scared. If we are going to go back to the same doctor, he might scold us. So it is essential that we need to tell the patient the importance of continuation of treatment, but on the same time, other hand, we need to be very careful that they should not get scared. Okay, so let's start. Dr. Niharika, go ahead.
Sir, there's a question in the chat box. I'll read it out for Dr. Niharika.
Yes, sir.
Was there any change in the nature or severity of symptoms during pregnancy or postpartum period here?
Sir,
Yeah, please answer.
Sir, as we see, her youngest children is of 11 years, and the illness started after the 11, duration of illness is of 11 years. So, in the birth of eldest and middle child, there was no though there was no such complaints.
So, in the period that she was lactating and did not have menses, the symptoms were not occurring.
Sir, no, sir. At the starting, at the lactation time, there was no symptoms according to the informants.
Let's move ahead, Dr. Niharika. I think we can take other questions at the end if there are any.
Dr. Param, can I just ask one question here if you allow me?
Sir, please. Who am I? Please ask, sir.
Yeah, Dr. Niharika, I think
Yes,
I
sir.
may miss, or I just want to ask one more thing. What was the reason for non-compliance and patient not agreeing to take the treatment?
Sir, patient's attitude toward the illness, that they need psychoeducation regarding the illness. According to her, it is not any psychiatric illness and she needed treatment. Even during our setting also, we have to take multiple sessions with the patient to psychoeducate her regarding the illness, and even after that, she started taking regular treatment.
Okay, thank you.
Dr. Niharika, let's go ahead, please.
Yes, sir. In general physical examination, a middle-aged female, obese, conscious, alert, she is cooperative for examination. Weight is of 60 kg, height is 5 feet 2 inch, PMI of 24.1 kilogram per meter square, pulse rate 86 per minute, regular, good volume. Blood pressure is 108/74 millimeter of mercury in right arm in sitting position. Respiratory rate is of 17 per minute, regular, abdominothoracic. Temperature 98.1 in right axilla. No pallor, icterus, cyanosis, laryngopathy, pitting pedal edema, raised jugular venous pressure, neck swelling. No visible hirsutism, acne, hyperpigmentation on the back of neck and armpits. In systemic examination, in CNS examination, patient is conscious, oriented and alert, and no abnormal involuntary movements are observed, no obvious musculoskeletal abnormalities, normal gait and posture. In cranial nerves are found to be intact with no asymmetry of face, deviation of angle of mouth, with all ocular movements being intact. Pupil is bilateral, reactive and equal in size. In cerebellar signs, ataxia is evidenced by absence of postural tremors, normal gait and normal tandem walking test, normal heel to shin test, negative rhombic sign and absence of dysdiadokinesia. No nystagmus, no intentional tremors observed during finger nose test. No slurring of speech, no hypotonia is evidenced by normal posture, normal gait, normal arm swing, and absence of pendular tendon reflexes. No dysmetria is evidenced by absence of overshooting or undershooting in finger nose test and absence of dysdiadokinesia. No neck rigidity. In motor symptom, muscle bulk is equal, bilaterally equal, muscle tone is bilateral equal, and muscle power is 5/5 in all 4 limbs. In deep tendon reflexes, they are normal bilateral, and planters are downgoing bilateral. In sensory system, crude touch, pain, temperature, bilaterally intact and symmetrical. Fine touch, sense of joint position are also bilateral, intact and symmetrical. Stereognosis and gravesthesia is intact, and 2-point discrimination is bilateral, intact and symmetrical. In cardiovascular examination, S1, S2 heart and no murmural heart. In respiratory system examination, bilateral equal air entry and clear, and there are no added sound. In GIT on per abdomen, it was soft, no guarding, rigidity, no non-tender, no palpable mouth. Bowel sounds are also heard normal. Mental status examination. In general appearance and behavior, a middle-aged female, kempt, tidy, endomorphic body type, looking appropriate to stated age, wearing clothes appropriate to weather and place, entered the examination room alone, unaided with normal gait, greet the examiner on being greeted, sat comfortably on chair without being asked with normal posture, cooperative during the interview, eye-to-eye contact was made and rapport established. Psychomotor activity is normal. In speech, it is normal rate, tone, volume, and normal reaction time. It is spontaneous, relevant, and goal-directed. In mood and affect, subjectively, मैं ठीक हूँ, and objectively, euthymic, average range, reactive, stable, congruent to thought process, and appropriate to the situation. In thought flow is normal, and no formal thought disorder was elicited during the neutral free-flow speech sample. In content, नमस्ते, आप कैसे हैं? पेशेंट, नमस्ते डॉक्टर जी, मैं ठीक हूँ. डॉक्टर, अच्छा, हॉस्पिटल कैसे आना हुआ? पेशेंट, बीच बीच में तबीयत खराब हो जाती है इसलिए. डॉक्टर, अच्छा, कैसे, थोड़ा विस्तार में बताएंगी? पेशेंट, मुझे नींद आने में परेशानी होती है और ऐसे तबीयत बिगड़ जाती है. अच्छा, और क्या क्या होता है उस दौरान? पेशेंट, बहुत छोटी छोटी बात पर गुस्सा आने लगता है, शरीर सुस्त हो जाता है. डॉक्टर, अच्छा, ये दिक्कत कब शुरू होती है, थोड़ा बताएंगे? पेशेंट, ये तो मुझे कई सालों से हो रहा है डॉक्टर। जब मुझे महीना आने वाला होता है तो उसके 3-4 दिन पहले से तबीयत बिगड़ने लग जाती है, और महीना तब जाती है हर महीने, तब हमें पता लग जाता है, और जब महीना खत्म हो जाता है तो उसके 2-3 दिन में मैं ठीक हो जाती हूँ और काम काज भी करने लग जाती हूँ। डॉक्टर, आपने बताया था छोटी छोटी बात पे गुस्सा आता है, तो ये गुस्सा किसके ऊपर आता है? पेशेंट, बच्चों के ऊपर, कभी घर वालों के ऊपर आ जाता है। डॉक्टर, तो उस दौरान घर वालों के साथ कैसा व्यवहार रहता है आपका? पेशेंट, मन उदास रहता है, किसी के साथ बात नहीं करती हूँ, सुस्ती सी लगने लगती है, तो इनके पापा भी काम में मदद करवा देते हैं। डॉक्टर, अच्छा, साथ में और भी कोई दिक्कत आती है क्या? ज्यादा टेंशन लेने लग जाती हूँ मैं। डॉक्टर, टेंशन के बारे में बताएंगे थोड़ा? पेशेंट, हाँ, बच्चों की टेंशन हो जाती है, कहीं बाहर खेलने कूदने में लड़ाई ना कर ले, मना करती हूँ तो वो भी मजाक बनाने लग गए हैं, मेरा कभी कभी तो बदमाश है। डॉक्टर, वो ऐसा क्यों कहते हैं? पेशेंट, घर वाले कहते हैं कि मैं बेवजह इस बारे में टेंशन ले लेती हूँ, मगर मैं क्या करूँ, मेरे दिमाग में उस समय ख्याल आ जाते हैं, और घर वाले समझाते हैं तो मैं शांत हो जाती हूँ। डॉक्टर, अच्छा, और भी कुछ महसूस होता है? पेशेंट, हाँ, ये भी बाहर जाते हैं, और अगर रात की ड्यूटी में तो टेंशन हो जाती है कि कहीं हमें छोड़कर चले तो नहीं जाएंगे किसी के यहाँ। डॉक्टर, अच्छा, आपको ऐसा क्यों लगता है कि वो आपको छोड़कर किसी और के पास चले जाएंगे? पेशेंट, मैं बीमार रहती हूँ इसलिए लगता है, ऐसा कुछ किया तो नहीं है उन्होंने, पर ये मेरे मन का वहम ही है, मुझे मेरे घर वालों ने भी समझाया है कि ऐसा कुछ नहीं है, मगर फिर भी कभी कभी ऐसा लगने लगता है कि कहीं और औरत का चक्कर ना चल रहा हो, बस इसलिए मैं इनको फोन कर लेती हूँ 2-3 बार, बात हो जाती है इनसे तो मन को आराम आ जाता है। डॉक्टर, अच्छा, ऐसा आपको हमेशा ही लगता है? पेशेंट, नहीं डॉक्टर, जिस समय महीना आने वाला होता है उसके आसपास ऐसा महसूस करती हूँ, फिर थोड़े 2-3 दिन में ठीक हो जाती हूँ। इम्प्रेशन, आइडियाज ऑफ इनफिडेलिटी इन possession, no sensory distortion, deception elicited during the interview and history. डॉक्टर, अच्छा, आपसे एक सवाल पूछेंगे जो हम अक्सर सबसे पूछते हैं, कभी आप अकेले या साथ में बैठे हो तो कानों में कोई आवाज सुनाई आती है जो किसी और को सुनाई या दिखाई नहीं देती? पेशेंट, नहीं, ऐसा तो कुछ नहीं है। इन हायर मेंटल फंक्शन, level of consciousness is alert, oriented to time, place, and person, attention and concentration in digit span test. Patient is able to recall 3-digit forward and 3-digit backwards, and able to do up to 2 subtraction in 30 seconds on 100 serial subtraction test. Impression is aroused and sustained. In memory, remote memory, patient is able to recall her date of birth and able to recall her year of marriage. In recent, patient is able to recall what she had in dinner last night and able to recall 3 unrelated objects after 5 minutes. Immediate memory, patient is able to perform digit span test as mentioned earlier. In general fund of knowledge, patient was able to answer following questions: Capital of India, New Delhi. Prime Minister of India, Modi ji. How many months are in a year? 12. And patient was able to do simple verbal calculations and able to do written and verbal complex calculations also. Impression is average fund of knowledge. In abstract thinking, proverbs, 9-2-11 होना, भाग जाना, घर की मुर्गी दाल बराबर, घर में कोई वैल्यू ना होना, पेट में चूहे कूदना, भूख लगना. इन सिमिलैरिटीज, बर्ड एंड प्लेन दोनों उड़ते हैं, एक पंछी है और एक मशीन है. एप्पल एंड ऑरेंज दोनों फल हैं और रंग अलग अलग हैं. Impression is abstract. In judgment, social judgment is intact. In test judgment, house on fire test, फायर ब्रिगेड को कॉल करूंगी, अननोन लेटर टेस्ट नहीं उठाऊंगी, एंड पर्सनल test judgment is intact and personal judgment is also intact. In impression, judgment is intact. Insight, डॉक्टर, क्या आपको लगता है कि आपको कोई परेशानी है? पेशेंट, हाँ डॉक्टर. आपको आपके हिसाब से इस परेशानी की क्या वजह है? पेशेंट, जरूरत तो आपके हिसाब से इसके लिए क्या इलाज की जरूरत है? जरूरत तो लगती है डॉक्टर. मैं दवाइयां पर हमेशा ठीक हो जाती हूँ, मैं चाहती हूँ ये जल्दी से बंद भी हो जाए. Impression is partial. In diagnostic formulation,
We can wait, doctor.
yes.
Yeah, any
Sir, one
clarification?
Sir, when was this MSc done? In the perimenstrual phase or between the menstrual cycles?
So in between the menstrual cycles.
In such
Sir,
a case,
yes, sir.
it is very important, in my humble opinion, to specify this aspect, whether this was done in the active phase of the illness or inactive phase of the illness. And in such a client or a patient, 2 MSCs done in the one in the phase of the active illness and second is in the remission or whatever you like to call it, would be better a way to present it. And just a suggestion, Pankaj sir.
Yes, sure.
Yeah, any other query?
Good morning. Hello.
Yeah.
Good morning. I'm Dr. Kshitij from Safdarjung, third year PG. Dr. Niharika, I just wanted to ask, the thought content you described, that the patient says कि कहीं बच्चों को कुछ होने जाए, कहीं पति का कुछ अफेयर चल तो नहीं रहा है. इस तरीके का
Yes,
जो
sir.
thought she is describing,
Yes,
could
sir.
it be a possibility of OC symptoms which are flaring up during the menstrual cycle rather than paranoia or psychosis per se? Because with the level of insight and the rapidity with which the symptoms are waxing and waning, so is that a possibility that we can entertain?
Dr. Niharika.
Actually, I
So
think
it,
if we go by the phenomenology of the patient. So to say it as an OC-like symptomatology, all those characteristics which is required to establish an obsession has to be there. It is an apprehension in the patient. मेरे बच्चों को कुछ होना हो जाए. Also, there is there is a clear-cut suspiciousness was present in the patient, like she was suspecting the character of the husband, making a phone calls. Unless or until she is not able to talk to the husband, she will not feel satisfied. So based on the descriptive psychopathology, it is more of a paranoia rather than an obsession.
Okay, sir. Okay, sir. Thank you.
One more thing,
Doctor-
Dr. Niharika,
yes.
whether this MSc was done after the treatment was given to her or at the time when she presented to you?
Sir, when she presented to us after 15 to 20 days of treatment, sir.
Because Dr. Manoj clearly said that she was not aware that the symptoms were related to the menstrual cycle.
Yes, sir. Yes.
But your answers were having all those menstrual cycles relationship.
Yes, sir. We have psychoeducated the patient, and after the after we started the treatment, 15 to 20 days after the treatment, MSc was done. Sir.
Okay, and the treatment was antipsychotics.
Sir, we have started on tablet escitalopram, sir, 10 mg and tablet risperidone 2 mg.
And after 15 days, we did this.
Yes, sir. Around after 15 to 20 days. Sir.
Okay, fine. Any other query?
Dr. Pankaj, there are a couple of questions in the chat. Have you taken them?
I'll be doing it. I think first.
Yeah, anybody wants to ask?
One more question, Dr. Niharika.
Yes,
Have we done
sir.
MSc in the active phase of the illness, be it perimenstrual or the mood or the psychotic state? Any MSc which was done in the active phase of the illness?
No, sir. Active during the active menstrual phase, sir. I haven't.
Okay, thank you. That's clarification.
Okay. Dr. Niharika, there's a question in the chat. I would like you to clarify that. Any possibility
Yes.
of personality issue? Maybe she has a fear of abandonment and presenting as an idea of infidelity. Maybe there is aggravated during premenstrual period.
Sir, when we ask the morbid personality is well adjusted, so there are in the history, so there are no any history that she was fearful regarding the abandonment from the husband. So ऐसा पहले नहीं था. It was started after the like for since 10 years, like 10 to 11 years old.
Okay. There was no obvious personality disorder, but maybe some traits were there which later on. Have you assessed her on these lines?
Sir, I have asked, but I haven't applied any personality assessment scale.
Okay, fine. Any other
Doctor,
query?
I would like to add
I
one
have a
more
question
line.
here.
Here, I
Sure.
would like to add one more line.
Okay.
Actually, had it been a personality disorder, these are the people who are likely to come into contact with whether the physician or a psychiatrist very early in their life. Because the marriage was very long period of time. Had there been some adjustment issues or because of the personality, so they would have definitely taken either some family intervention for the turmoil which is happening in the life, or they would have taken the patient to some kind of psychiatrist. Before these 11 years, there was never been so much of interpersonal issues that the patient is requiring either the family or there is an intervention. Borderline personalities, those who are having this kind of feeling of amendment and abandonment, either they are having a physical fights or verbal fights, physical fights, that their family get involved in this to settle the issues, or they will be taken to some kind of psychiatrist or some kind of mental health specialist. But before this 11 year, there was never been any history suggestive of this. This was very atypical in this particular case. So at least the possibility of a personality disorder is very unlikely in this case. And the second thing is actually this was very atypical in this particular case is when the PMDD usually you start, whether it will start only after the patient has completed her the family, because in this particular case what we are seeing is she had these PMDD symptoms only after her the second child, which is now 11 years old. So that was a very atypicality. Usually the woman with the PMDD, they might have premenstrual symptoms even before that one also, which was very minimal in this particular case, and they got exacerbated after the second birth of the child. And the third thing which is contributing in this particular case is there is a family history of psychotic disorder in this patients, so which might also be clearing. And the MSc which is being done during the intermenstrual period, because the patient is having memories. Actually, I used to suspect, I used to do this, I used to do that. So she was able to narrate. So these ideas of infidelity that is being, Dr. Niharika has presented is actually from her memories that she was behaving in this particular manner. So when we actually examined this woman, there was no active symptomatology, and the husband was able to say that अब इस तरह ज्यादा दिक्कत नहीं है, लेकिन ये मेरे पर शक कर दी है. So the ideas was made because it is arising more from the memory rather than from the actual infidelity or any behavior done by the patient during that period of time.
Wonderful. Dr. Pankaj Kumar, I think you were asking something.
Yeah, Dr. Manoj has given the answer to those questions, I believe. Thank you, Dr. Manoj.
Okay. Any other query?
Just clarify one more thing, Dr. Niharika, just one more thing. Can you establish without any doubt that she had psychosis, any psychotic symptoms, delusion, hallucination in your MSc? Could you do that in any point of time?
Sir, I have asked sir, hallucination. They have no behavioral symptoms according to the husband informant about the visual hallucination, but I haven't asked the question directly, sir.
Okay. Let's move ahead. Dr. Niharika, go ahead.
Yes. Diagnostic formulation. Mrs. V, 36-year-old female, studied till 10th standard, married, belonging to Hindu nuclear family of upper lower socioeconomic status, resident of Ghaziabad, presented with the family history suggestive of similar psychiatric illness in mother and possibility of psychotic illness in brother. Significant past personal legal history with current illness of 11 years, of abrupt onset and episodic course, with precipitating factor being onset of each menstrual cycle and predisposing factor being family history of similar illness in mother with heat complaints of delayed onset of sleep, low mood and decreased energy, and ideas of infidelity lasting for 8 to 9 days during the phase of menstrual cycle, associated with socio-occupational decline, when a physical examination is within normal limit, and MSc concurred with the above findings with intact judgment and partial insight towards illness. The provisional diagnosis, according to ICD-10, premenstrual tension syndrome, N94.3, and according to DSM-5, premenstrual dysphoric disorder, 625.4, was made. According to ICD-11, premenstrual dysphoric disorder, GA34.41 was made, with differential diagnosis of cyclothymia 34.0 and persistent delusional disorder F22.0 and recurrent depressive disorder current episode moderate F33.1 was made.
Dr. Pankaj?
Yeah, any query? Because there is one query in the chat that is from Dr. Darshan Kalal. Why olanzapine wasn't restarted despite previously having good response and no side effects. And second is why risperidone was preferred in this case, as risperidone can cause menstrual irregularities. Dr. Niharika, would you like to say something?
Sir,
Actually, regarding the decision to start risperidone, why not olanzapine? Actually, maybe this is may not be the right forum to ask this particular question.
Yes, sir.
But actually, I personally believe that olanzapine in a woman is absolutely a contraindication. We can have a debate on this particular topic. Olanzapine having this metabolic side effect, weight gain, all those problems. I think I personally believe olanzapine should be contraindicated in a woman gender. And she was also, over the period of time has gained weight, but it may not be completely attributed to olanzapine only. So my preference for olanzapine will never be there in any woman gender. We can able to debate this particular topic at any point in time or any other forum. So that was one of the reason. And the second thing is actually the risperidone was started in a very low doses, and it was already the patient, because patient was believed to be a case of persistent delusional disorder or schizophrenia. So it was very difficult for us to immediately withdraw all those antipsychotic and consider totally a different diagnosis and start patient totally anew. We only added the initially this escitalopram, and over the period of time we are observing that those premenstrual symptoms are reduced in intensity, and a little bit of this low dose of risperidone is also helping the patient in a reduction of those manifestations. So we are continuing with a very low dose. We have not increased it, and we are planning to reduce the dose of risperidone in future also.
Okay. Anybody else?
Sir, can I ask a question, sir?
Yeah, sure.
Dr. Niharika,
yes, sir.
in the diagnosis that you have made, premenstrual tension syndrome, where do you figure those paranoid ideas or ideas of persecute infidelity in the diagnosis? Can you subsume them here? Or is the diagnosis far more overarching than a premenstrual tension syndrome here? Is my question clear?
No, sir.
The patient in the history and the formulation has
Yes, sir.
ideas of infidelity.
Yes, sir.
In the diagnosis that we have made provisionally, are we able to subsume those symptoms easily, or is the diagnosis rather much more doubtful?
No, this is actually, Dr. Pramji, this is a very, basically,
Unique.
but basically it is very difficult to discern and dissect whether we just put all these symptomatology, because there is a onset and the resolution of these symptomatology is during those premenstrual phase. And that is why actually we are considering it to be a part and parcel of this PMDD syndrome also. This PMDD syndrome actually, if we go by history, it is used to be called as cyclic psychosis.
Yes,
and if we go through these literature review, there are certain paranoid ideation has been mentioned in those PMDD symptomatology, and that is why we didn't entertain a separate diagnosis and wanted to continue the medication for that syndrome. Rather, we subsume it to be a part of PMDD syndrome only and wanted to treat this PMDD primarily.
I just
That's
wanted
why
to
it is
hear
not
from the
getting.
PG, sir. I just wanted to hear what you're saying from the PG, not from you, sir. पीजी को बोला
Actually, this is a case which requires, a lot of inputs from everybody, because we 100% cannot be, sure about, because there is a lot of difficulty in coming to this kind of conclusion in this particular case.
Absolutely.
And a person who has been 11 years treated on the lines of schizophrenia and persistent delusional disorder, and suddenly we are changing the diagnosis, it requires a lot of, inputs from other people also. And that is why we thought of bringing this particular case on this larger forum, and can able to get the inputs. And if we are making any mistake, that can be, enlightened to us, so that we can help this patient in a much better manner. That was the intention.
So, this is Dr. Vishal. So can I ask now, Dr. Manoj, should I ask you or Niharika, what is the treatment plan for this patient? And what do you think is the long-term prognosis for this patient?
Dr. Niharika, can you try and answer, please?
Yes, sir. We are planning to further serial MSCs for the patient, and currently we have spoken to the patient. She is currently reporting improvement on these medications only, and we are planning to, sir, planning to optimize the treatment according to the symptomatology over the course of the illness, and sir, we'll further we'll psychoeducate the patient regarding the need for the.
Niharika, I'm not Niharika. Sorry, but I'm not getting the answer I'm looking for. This is very. The statements are there, but you need to tell me how you're going to plan, how you're going to treat this patient. For a patient of PMDD,
yes, sir.
What is the usual way of treating a patient of PMDD? One,
sir,
and second.
Yes, sir.
Yeah, go ahead.
Just a minute, Dr. Vishal. Just a minute. Dr. Niharika, have you made a slide on management plan or something?
No, sir.
This is the last, na?
Yes, sir. Yes, sir.
Okay, fine. So you should also bring that management plan or treatment plan, so that one can work on it. Okay. This is why it is causing a confusion, and that is why Dr. Vishal is asking this. So what we need to do is, we need to have a management plan for every case we present. Huh?
Yes.
So now, what is the plan? Short-term plan, immediate plan, and the long-term plan. This is what we need to do. So now you can answer Dr. Vishal's answer.
Sir, in PMDD, sir, selective serotonin reuptake inhibitors are the first line of treatment for the PMDD. So we have started the patient on escitalopram 10 mg, and we'll continue to continue the same treatment. Sir, as the patient is reporting improvement in the symptoms, and she also started thinking of going to work after 6 months of gap also. So, sir, my plan is to, sir, continue the same dose, sir, as she is reporting.
So escitalopram 10 mg.
Yes.
Any antipsychotic you want to try, or you don't want to give anything?
So currently we are giving 2 mg risperidone.
Okay. Like somebody was asking, will that cause any, or has that caused any prolactin issues, menstrual irregularities?
Sir, till now, sir, patient hasn't reported yet that I need menstrual irregularity. If in future there is irregularity, we can change the drug accordingly, sir.
And what is the age of the patient?
The 36-year-old.
36. So PMDD long term, how long does the PMDD last? What does literature says? How long does it last? Will it last till the menopause? Will it end before it? Will the severity reduces over time? Will it stay the same? Because you need to tell the family. You will probably tell family all this stuff. You will have to tell in education when you're educating.
So I went.
Yeah, because it's not your fault, Niharika, because this case is not presented anywhere. So they think about this in terms of, if you want to educate, You
Yes.
also need to know schizophrenia में आप बोल दोगे, bipolar बोल दोगे, you can say long term है, you have to take it almost lifelong, stuff like that. Here, what will you say? The PMDD hai, so till menses are there, you have issues. Once the menstrual cycle stops, you should be all right. That's what you're going to say. So this we need to look at what literature says.
Yes.
Frankly
Yes.
speaking, I have not read about it. I'm just asking you because this question is coming to my mind.
Yes, sir.
Maybe Dr. Manoj can enlighten us if he has read about or can help us. And also, since PMDD causes trouble only for 4 to 5 days in a month, right?
Yes.
Maybe 6 days. Some people for a week, some people 4 or 5 days.
Yes.
Does it make sense to continue risperidone 2 mg throughout the month?
Regarding this management plan, I would like
Haji.
to add, Dr. Vishal.
Sure,
Actually,
sir.
as far as the literature is concerned, actually they start the medication nearly about a week before the onset
Yes.
of menses, and
Yeah.
they titrate. Fluoxetine is very well. The largest literature is related to the fluoxetine use, and they have gone up to 40 or 60 milligram also to control the symptomatology. So in this patient also, actually, we were thinking of giving the medication only during this premenstrual phase and continue the medication till her menses stops. So as per the available literature, the treatment has to be given only during this particular phase, and we can give the drug holiday to the patient in between. Similarly, I was thinking on the lines of using the risperidone, whether should I continue with this or not? Because little bit of diagnosis was in a doubtful, so we are slightly reluctant on a back foot to stop this risperidone or not. And if, say for example, if the same principle, this improvement in the patient's condition remain persistent, then we might also consider as innovative to give only risperidone during this premenstrual phase and continue till her menses lasts. But that's actually a future, and automatically it is a long-term course of the patient, and his treatment, persistence of treatment with us will decide whether we should able to take this particular step or not. But as far as PMDD is concerned, actually this escitalopram, I'm actually in a mood to give a drug holidays to this patient in between, and one would like to unnecessarily add to her burden of getting the medication coming all the way to IBAS every 15 days. So I just wanted to prevent that frequent visits, and we'll consider this only during this premenstrual phase and during her menstrual phase.
So my suggestion, if I can give a suggestion, just think about it. I think you are very right there that you want to reduce the drug load on the patient. And so PMDD usually should respond to SSRIs. You also very interestingly said that in literature before, in classificatory system, it was called cycloid psychosis. And आपसे बात करते हैं, just I realized that I had a similar patient who had paranoid ideations during menstrual cycle only, and then she used to settle down. So I have not tried I in fact tried only antipsychotic there, only during the menstrual cycle, and other days I was continuing SSRI. So if you want to try for a couple of months, try escitalopram, and maybe slowly taper down as risperidone, or I would prefer aripiprazole, but anyways, risperidone, and reduce it maybe to 1 mg or 0.5 mg, and see how lower dose you can stop those psychotic ideas or those ideas of infidelity.
Okay. May I add to this, Dr. Vishal and Dr. Manoj?
Yeah, sure.
You are the chairperson.
Yeah. Okay. See, the symptoms, they vary patient to patient. So in some patient, it lasts only for a week, but in some cases, it has lasted for 21 days, 3 weeks. So we need to cater the patient's need. If patient is having 21 days a problem, then you cannot have a drug holiday. But if he or she, or she is having this for less than 10 days or something, one should definitely consider drug holiday. Dr. Manoj, have you thought of OCPs or any additive agents like calcium, vitamin D3? which have shown to show better improvement?
No, definitely. Actually, no, these are the cases which need not to be treated only by the psychiatrist. There is a requirement from the gynecological perspective or endocrinologist is required. This
Mhm.
low level of estrogen and increase in the progesterone is one of those etiologies which explain the possibility of this PMDD. So when this
Okay.
estrogen and progesterone are the primarily endocrine hormones which are leading to this development of syndromes, I think the endocrinologists as well as this gynecologists need to be the part of our treatment of our patients. So
Yes.
I'm definitely like to take their viewpoint in if there is any advancement which has happened in this field of management of PMDD. So I will definitely like to take any viewpoint or any suggestion from them and incorporate in the treatment of this patient.
So there is a meta-analysis which was done in 2021, which is one of the largest, which was done in India, and it states clearly that it cannot be treated by one this thing. It needs to be treated by combination of specialists. Okay. There are certain questions in the chat box. How can we exclude the diagnosis of prodrome of schizophrenia? How will we rule out bipolar spectrum except temporal relationship with the menstrual cycle? Dr. Niharika. This was asked by Dr. Lavina.
Yes, sir. Sir, it's been 11 years of illness, and sir, symptoms are remitting and they are coming episodically. And so in between we have explored that in between the menstrual phases, she is completely normal. She's completely asymptomatic, and she again started having the symptoms just before the menstrual phase and in between in the menstrual phase only. So, sir, prodrome of schizophrenia, sir, it should be continuous, and it is long-term illness.
Okay.
So, prodrome should not last for 11 years.
Yeah, it can last for years, but not 11 years.
Yes, sir, it can last for years, but 11 years is.
Okay. The another question was PMDD be managed with SSRI only. This you have already answered. Okay. Any other query?
Yeah, Dr. Niharika.
Yes.
Sir, may I ask one?
Please, Dr. Pankaj, go ahead.
Dr. Niharika, as you told, patient is a long-term history of illness, 11 years, and she has taken treatment from various psychiatrists and other therapists and mental health experts. And every time she leaves her treatment and there is a history of poor compliance or non-compliance, and you told the reason, she says कि मुझे कुछ नहीं हुआ है, and when she gets better, she says, मैं ठीक, I don't require treatment. So why should I take treatment? Okay, fine. Point well taken. So this time also you had started treating her, and she's getting better as in the past history also. What do you plan to do separately to ensure the compliance of the patient and she doesn't stop the treatment this time? And as you told, you've done psychoeducation. I believe psychoeducation is a very mild term, and a lot of almost every psychiatrist or mental expert do that in their own way. So what differently you plan to do so she can ensure treatment and she should not suffer again and again like in the past?
So we have psychoeducated family members also, and I have followed up the patient regularly, sir. So it's been.
How do you follow the patient regularly?
Sir, I have asked. So they came. They every time come to OPD and they ask the treatment.
So what do you plan to do differently so she should not stop treatment this time? That's my question basically.
May I add to this question?
Sir.
Actually, what is the patient's husband has told me that actually he was afraid that the doctors will scold him why you stop the medication. But there are other reasons also, like affording a treatment from consultation charges of the private psychiatrist, and then the medication. So these were also something which is bothering the patient, and that is why there is a little bit of we can say a little bit of poor support from the husband side also to take the patient for the treatment, because she used to become better and he used to feel okay, the problem has been resolved. Why I take the patient. So whenever the problem used to get exaggerated, that is why he will think of taking the patient to a psychiatrist. With IBHAS, there are certain advantages. Every medication is given free of cost. Only the problem is actually the patient used to have visit every 15 days, which is only the deterring factor. Otherwise, the our attrition rate at IBHAS is significantly low. And one of the main reason for that one is that we provide free consultation and we give the free medication. Every medication which is being provided written on our prescription is being provided to the patient free of cost. So these are the two factors which will definitely act in our favor, and the patient may remain continue with us. But definitely there is a need for more psychoeducation, the need for continued medications, and the whatever the treatment plan that we will tell the patient, we will take her into concurrence, and then only we'll take a decision. So whether we plan for drug holidays, so everything will be done only with concurrence of the patient as well as her family members. So these are the things which we plan to do extra in this time, and hopefully only the time will tell whether she remain continue with us or not.
That's great, sir. But just to go back a little bit in the history, Dr. Niharika said patient family is like upper middle class. That means they have a good amount of money. Good amount means like decent amount of money. I don't know what's she said ki patient family is quite supportive, helpful and cooperative and takes care of her and her needs. So I believe that little bit is contradictory. Both either she was not doing the right thing properly or something is missing. That's one thing. And secondly, sir, if you said just now, like you plan to continue antipsychotic for some time now, and before deciding to taper it off and giving her some medicine holiday. So as we all know, we get depot also in IBHAS. So do you plan to put her in depot or to take care of the compliance issue?
As far as depot is concerned, I'm not in a hurry to think about a depot preparation. Rather, I'm in view of stopping this risperidone also. So I might continue with only the escitalopram, and if there is a need be, I might increase it. And if these increase in the SSRIs can control all those symptoms, including the psychotic symptoms, I will definitely give only the SSRIs. But had the patient continue to show some those psychotic symptoms that we have mentioned, then a little bit of antipsychotic, and that will be only used in line with the SSRIs. We will increase the dose, we will decrease the dose, and we will stop the dose, and we will give the drug holidays. But at least definitely not risperidone depot preparation to the patient, because we are reasonably certain that we are not dealing with the case of delusional disorder or schizophrenia.
Any other query or suggestion?
I think it's been very interesting. I agree with Dr. Manoj's thought process and what Niharika has done. Good. I think it'll be interesting that by the next case conference, if you can give us some feedback on, or maybe after 2 months, you can get some feedback on another case conference. What has happened to this patient? That'll be very much more important or learning for us.
Yes, sir. Sure, sir.
Yeah. I might suggest some points. Dr. Manoj.
Sir, please add.
Okay. Because we know that she's having a cyclic this thing. If we call her on the just 1 week prior to the her menses and to the OPD and reinforce the treatment every month, this is one way of telling, reinsuring that she's taking medication. Second, that we should bring objectivity to the symptomatology. We should give some scales like PST, or we should ask her to note down her symptomatology with a diary with the menses, so that even she should be aware that what is happening with her. And we should try also that OCPs, that especially the 24 days OCP has shown some good improvement in this. Along with this, if required, a high dose of calcium and what is that called? Some pyridoxine also has shown some improvement, and vitamin D3. So we can always think in those terms and try to bring objectivity. Especially, we should prognosticate her with the and without treatment part. That how it is going to help. Okay. So maybe next time, as Dr. Vishal was asking, just share with us in the next this thing that how she has responded. And
Yes, sir.
I
Yes,
would
sir.
say
Actually,
it
all
was, yeah.
all those
good.
suggestions that you have given is very wonderful, and actually we would definitely like to incorporate and come back after 2 or 3 months with some more objective and what has actually has happened to the patient. We will update the group.
Great. Thank you so much. Thank you. Paramjit.
This case must be published, sir. This is a perimenstrual psychosis. There are very few case reports on the same. So a request to the presenter and Dr. Manoj to kindly consider publishing such a unique case report.
Yes, sir, sure.
Sure, we will definitely do this.
Sir, nothing else other than a wonderful case, sir. We have some.
I think Dr. Niharika has presented very well, and it was very brave of Dr. Manoj to bring this case. And I would encourage my colleagues to do the same, so that we can have such an interesting discussion. So over to Dr. Paramjit and Dr. Vishal. Thank you from my side.
Sir.
Any quick comments from Dr. Om Prakash? Some other seniors were there.
Dr. Brijesh is there. Brijesh, sir, I think apna ex-Ibhas, if I remember correctly, Brijesh. Anything you want to add, Dr. Brijesh?
Yeah, thank you. It's really a very atypical case. I haven't seen such type of presentation. And the PGs and SRs who are attending this case, they will be really benefited from such presentation. The patient treated for psychosis and turn out to be having a neurotic disorder, which in itself have a symptomatology tendency to present with psychotic symptoms. So we have to be careful with history in detail, and that will bring the things. And in long term, we will see what will happen. Cross-sectionally, it is neurotic disorder. And hopefully, let's see what happens with the management and follow-up after 2 months. We can see some new things. Thank you, Dr. Manoj, for bringing such a good case. It's really a mind-opening type of case. Thank you.
Thank you, sir.
I also see, sir, Somnath sir is there. Sir, if you're in the meeting, sir, I see Somnath sir. Hi, sir.
No,
Hi, sir,
Vishal and
welcome.
Paramjit, I want to just thank you for having me with you. This is my, I think, first experience with this kind of academic forum. Thank you so much. And it's been a wonderful hearing all of you, particularly this postgraduate from my previous institute, Niharika's presentation. Gone on very well. I should definitely thank and congratulate her. And Manoj, my previous ex-colleague, has wonderfully discussed the case. Of course, there are a lot of unsettled issues in this case. I don't want to go into the details, but all those things need to be settled before really you want to go by what Paramjit has suggested, that's publication. Otherwise, it may not be accepted for publication. So that you will do. I just want to hint at one kind of suggestion is that I find there is an over kind of emphasis on pharmacological management. Of course, I definitely agree with Manoj's stand that at least he says that he plans to manage the patient only with escitalopram and no antipsychotic. That's very good, at least. But at the same time, there should be quite a bit of work to be done on the psychosocial front, basically with the family, both the patient, husband, and if anybody else is involved in the patient's caregiving. So please think of that. Somebody needs to talk to the family to how to handle the patient during the active phases. I think that's very important because normally the reactions could be sometimes violence to patient's behavior. So that we have to be very, very careful. We tend to ignore those areas normally with our over kind of preoccupation or emphasis with pharmacological management. That's all. Thank you and congratulations and thanks a lot to Paramjit and Vishal.
Thank you, sir.
Thank you, sir.
Very nice to hear you, sir. Very nice. I also see Dr. Rajshekhar from Hyderabad, if I'm not wrong, but I can't see any Right. Dr. Rajshekar? Or maybe because I don't see any mute or unmute button. I don't know if his speaker is on. Anyways, Paramjit. So any closing?
We can close the session, sir. It was a wonderful
Right.
one.
So thank you so much. I again request all the budding psychiatrists here to please come forward and submit your cases for the next month's case conference. I'd like to thank all the seniors who joined us from the busy schedule. I thank all the PGs who have joined us. That's very nice. I thank Niharika for presenting this case. It wasn't that bad, I know, Niharika. and you get a certificate also. So this is good, all good for you, and think this will help you do better in your future. So I wish you all the best, and thank you, my friend Manoj. You were both colleagues in IBHAS. So nice to see him on Sunday. So please, I request again, more and more of you to please come forward. हमारे पास waiting list होना चाहिए. On the other hand, we should be saying, हमारे पास अभी time जगह नहीं है. It should be like that, not the other way around. So please look forward. Please come and participate. Actually, thank you, everyone. Thank you, Dr. Pankaj, for chairing. Thank you, our Vice President, Dr. Pankaj Kumar. He was here. Paramji, thank you for coordinating with the faculty and everyone. Dr. Brijesh. Especially thanks to Dr. Somnath Sen Gupta. Very nice to see him. Dr. Om Prakash, though he was here, he did not. But thanks for being there. So he did not. I don't know if he's maybe busy with some meeting, but I will again like to see him next time. Thank you all for joining. I'm going to end the session now.
Yes.
Have a nice Sunday. Thank you, everyone.
Thank you. Thank you.